Today, we're going to jump right into a really high-stakes medical detective story. It's all about the battle against a superinfection that's taken hold of a life-saving artificial heart valve. We're going to explore what it really takes to fight an enemy that's not only microscopic, but has also figured out how to resist our best weapons. The stakes here? They're literally life and death.
So just think about that for a second. A device that was put in to save someone's life, a prosthetic heart valve, suddenly becomes the main battleground for a really dangerous infection. How in the world do doctors fight an enemy that's basically set up camp on something inside the heart, beating with every single pulse? Well, let's dive in and investigate.
Okay, so this condition has a specific name. It's called prosthetic valve endocarditis, or PVE for short. And it's exactly what it sounds like, a severe infection that takes root right on an artificial heart valve. And, as we're about to see, this makes it a uniquely complex and incredibly dangerous foe.
All right, so for our first section, let's start by understanding the stakes. Just how dangerous is this infection, really?
Well, here's the absolute core of the problem. You often can't beat PVE with just antibiotics. In fact, treatment fails a lot, especially if the bacteria is super aggressive or if other complications pop up. So, right from the get-go, you're dealing with a formidable opponent.
So, when a patient comes in and the doctors suspect PVE, the investigation kicks off immediately. The clock is ticking, and a fast, coordinated response is absolutely critical.
The medical team takes 3 urgent actions right away. First, the patient gets hospitalized, ideally somewhere with cardiac surgery on standby. Second, they collect the evidence. This means drawing multiple blood cultures over time. It's kind of like dusting for fingerprints to figure out which bacterial culprit they're dealing with. And third, they start what's called empiric therapy, which is basically a strategic first strike.
And the strategy here is just so important. Notice the timing. It happens after the blood cultures are taken, but before the results are back. Doctors immediately start a broad-spectrum antibiotic treatment. They just don't wait. And that decision is a calculated risk that they have to take because of how sick the patient is. And that brings up a really good question, right? You might be thinking, why not wait for the evidence? Why not see what the blood cultures show before you start throwing antibiotics at the problem? Isn't that kind of like firing in the dark?
Well, the answer is pretty simple and pretty stark. With PVE, time is the one thing you just do not have. This infection can cause catastrophic damage and fast. So the strategy is to hit it hard with antibiotics that cover the most likely suspects, buying precious time while the lab gets to work on identifying the real culprit.
Okay, so that initial broad assault has bought them some time. Now the investigation can zero in on the specific bad guy. Those fingerprints from the blood cultures are about to reveal the enemy's true identity.
And boom, the lab results are in. Once the lab identifies the specific microorganism that's causing all this trouble, that broad-spectrum shotgun approach is over. The treatment now gets tailored, becoming a targeted, high-precision weapon aimed right at the identified culprit.
So who are the usual suspects in these cases? Well, the most common culprits include things like staphylococci, enterococci, and streptococci. And then there's this other group of slower-growing, kind of fussy bacteria we know by the acronym HASEC. For our case study, though, we're going to focus on one of the toughest of them all.
And this brings us right to the heart of the battle, the multi-drug takedown. Now we're going to see the sophisticated, coordinated attack that's required to defeat a particularly dangerous bacterial enemy.
Our prime suspect is Staphylococcus. When staph bacteria are the cause of PVE, they present this massive challenge that requires an especially aggressive and really well-coordinated plan of attack.
So what makes staph so tough? First off, it creates these things called biofilms. You can think of them like these protective fortresses where bacteria can just hide out, totally shielded from our antibiotics. Second, it's just notorious for developing drug resistance, and fast. And third, staph PVE is linked with really high mortality rates. This is a truly formidable enemy. So because of all those challenges, a single antibiotic just isn't gonna cut it. No. To defeat staph, doctors have to deploy a really carefully coordinated, 3-pronged attack.
Think of the battle plan like a special ops team, with 3 agents, each with a specific mission. You've got the primary agent, something like penicillin or vancomycin, that leads the main assault on the active bacteria. Then you have the synergizer, which is gentamicin, and its job is to boost the power of that primary agent. And finally, you have the biofilm buster, rifampicin, which has the unique and crucial mission of getting inside those bacterial fortresses to kill the dormant bacteria hiding out.
Okay, now this right here is a brilliant piece of strategy. You see, gentamicin is only used for the first 2 weeks. Why? Well, its job isn't just to help kill bacteria. Its main purpose is to prevent the bacteria from developing resistance to rifampin. It helps wipe out any mutants that might survive the other drugs, which makes sure that the biofilm buster stays effective for the entire treatment. It's just a fantastic example of medical strategy in action.
So, the initial battle might be won, but the war is far from over. This final phase is all about winning the long fight. It's a marathon of endurance, vigilance, and the long, hard road to recovery.
Just look at that number, 6. That's the minimum number of weeks of intravenous antibiotic therapy. This is not a quick fight. It's a marathon that requires total commitment from both the medical team and, of course, the patient. Now, you might be wondering, why not just switch to pills after a little while? Well, the standard of care for PVIE is parenteral or IV therapy. It's really the only way to guarantee a high, reliable concentration of the drug in the bloodstream to fight an infection that's this deep-seated. Switching over to oral therapy, that just carries way too high a risk of the whole treatment failing.
And throughout those 6+ weeks, the patient is under constant watch. We're talking weekly lab tests to monitor for drug side effects, careful exams to watch for devastating complications like heart failure, and repeat blood cultures just to confirm the infection is truly gone. The case isn't closed until the evidence proves it, period. And even after all of that, the fight might not actually be over. Relapse is a very real possibility. I mean, these infections are incredibly resilient, and patients have to know that any new fever or symptoms means they need to get checked out immediately. The vigilance has to continue long after the treatment officially ends. Which leaves us with one last crucial question. We've seen the incredible strategy and detective work that it takes to fight PVE today. But as bacteria keep evolving and becoming even more resistant, how are our strategies going to have to adapt to fight the super infections of tomorrow? Now that is the challenge that lies ahead for all of us.